Good afternoon, everyone. I'm Sir Franz, and our one of the few remaining lessons that we have for pharmacology would be this one, and we're focusing on drugs that affect the gastrointestinal tract. Okay, so our lesson for this afternoon is alcoholic liver disease and cirrhosis, and what the current management options are. So, for our discussion, we'll first take a look at how the body processes ethanol, what happens in acute alcoholism, in chronic alcoholism, in alcoholic liver disease, and pharmacotherapy of cirrhosis. Despite all the attention given to illicit drugs such as methamphetamine or shabu, alcohol abuse is far more widespread and claims many more lives. 50% of adults, so that's one half of all the people that you know who are adults, drink alcohol, half of them. And 10% of adults, which means 1 out of 10 adults, have chronic alcoholism. Worldwide, alcoholism accounts for 1.8 million deaths per year. So much like the use of tobacco, no, there are a lot of deaths that are directly attributable to the use of alcohol. So let's just discuss some of the pharmacokinetics related to alcohol use. Alcohol is absorbed unaltered in the stomach and the small intestines. Unlike most drugs, which are primarily absorbed in the small intestines, alcohol can be absorbed in the stomach. It is distributed to all tissues and fluids in proportion to blood level. So that means if the person takes in a lot of alcohol and the blood level of alcohol rises acutely, then that will equilibrate and lead to higher blood levels and tissue levels of alcohol, particular to the organs upon which alcohol is distributed, such as in the brain. Amount exhaled is proportional to the blood level, and this one is the basis for the breath test for alcohol. So remember that alcohol is also a volatile gas, much so that it is a liquid. So that if the blood levels of alcohol is high, then the amount of alcohol exhaled will also be high. And because this is a direct proportion, if a person is found to be or suspected to be under the influence of alcohol, and that person is subjected to the alcohol breath test, the levels of alcohol detected in the alcohol breath test will reflect the level of alcohol in the blood. And in the blood, the legal definition of drunk driving is 80 milligrams of alcohol per 100 ml of blood. If there is 200 milligrams of alcohol per 100 ml of blood, that will directly lead to the manifestation of drowsiness. So, ibig sabihin nun, kapag ikaw ay naaantok na after taking your drink, then it is estimated that within your blood, 100 ml of your blood will contain 200 milligrams of alcohol. Stuporous um, patients, after taking up alcohol, will have an estimated alcohol blood level of 300 milligrams per 100 ml. And stuporous means these persons have decreased levels of consciousness, and it is only with vigorous physical contact and a loud voice that you'll be able to awaken these persons. Coma and respiratory arrest will occur at levels higher than 300 milligrams. So let's now go to the metabolism of alcohol. There are three systems in the liver cell cytoplasm capable of oxidizing alcohol. And the most important of these three systems is alcohol dehydrogenase, which, if you will recall your previous years or past lessons, will convert alcohol to acetaldehyde, and that same enzyme, alcohol dehydrogenase, will have a second activity, and that is aldehyde dehydrogenase. So that means there is one enzyme, there is one protein that catalyzes both the oxidation of alcohol and aldehyde. Okay, so aldehyde, when acted upon by that same enzyme, aldehyde dehydrogenase, will be converted to acetic acid. And that system is the primary metabolic pathway for alcohol. The second one is microsomal ethanol oxidizing system. And this is only active whenever the person has high blood alcohol levels. So if the person or the patient has lower blood alcohol level, then the only system activated would be the alcohol dehydrogenase, aldehyde dehydrogenase system. But in higher blood levels, it will start to recruit the activity of CYP, also known as the microsomal ethanol oxidizing system. A minor pathway is the catalase system, which will convert the alcohol into water and oxygen when it produces hydrogen peroxide. So this is a peroxidizing pathway. Okay, so the CYP system is induced in chronic alcoholism. And what does that mean? If the person is a chronic alcoholic, then that person will continue to increase its expression of the CYP enzymes, the microsomal oxidizing system, so that chronic alcoholics will be able to metabolize alcohol quicker than non-chronic alcoholics because they have higher active enzymes or much more of the CYP system due to induction. So, high blood alcohol impedes drug catabolism by the CYP system and potentiates the effects of sedative hypnotics, narcotics, and psychotropics. These drugs, yung sedative hypnotics, narcotics, and psychotropics, are metabolized by the CYP system. So, in patients who are chronic alcoholics, if they take in a lot of alcohol and at the same time take in, for example, a narcotic, the CYP system will preferentially metabolize alcohol and not the narcotic, leading to higher blood levels of the narcotic and therefore augmentation adverse drug effects. So acetaldehyde formed is converted to acetate and utilized in the mitochondrial respiratory chain. So the acetate there will be spontaneously ligated to coenzyme A, forming acetyl coenzyme A. So if you take a look at this image, this shows you within the hepatocyte the different catabolizing systems. So first, draw your attention at the middle, where ethanol is acted upon by alcohol dehydrogenase to form acetaldehyde. Remember that this is an oxidizing pathway, which means that ethanol will release from itself a hydrogen, and therefore there should be someone or something that takes up that hydrogen. There is an entity that is reduced, okay, and that molecule is NAD. nicotinamide adenine dinucleotide. So after the action of alcohol dehydrogenase, ethanol will lose a hydrogen and form acetaldehyde, and that hydrogen will go into NAD, forming the reduced equivalent NADH. Furthermore, acetaldehyde will be taken up by the mitochondrion, and where that same isoform or isoenzyme of alcohol dehydrogenase, now aldehyde dehydrogenase, at the right portion of your image, will continuously oxidize the acetaldehyde to form acetic acid, and again utilizing NAD to form NADH. Okay, so that is the principal metabolizing pathway. If you take a look at the blue oblong on the top image, on the top of the image, you will see how NADPH, which is the reduced form of NADP, together with oxygen, um, catalyzes the conversion of ethanol into a diol. And this diol will spontaneously hydrolyze to form acetaldehyde. So in that mechanism, you will be utilizing the reducing equivalent NADPH, which serves intracellularly as an radical scavenging molecule. So let me emphasize that by the activity of the microsomal system or the CYP system, the levels of NADPH will go down, and therefore there will be less molecules that are capable of handling free radicals. Therefore, the free radicals inside the hepatocyte will increase, and this will lead to damage in the hepatocyte. Okay. Likewise, in the peroxisomes, which is in the bottom of this image, the minor pathway utilizing catalase, you will form hydrogen peroxide, which is also a radical oxygen species, and therefore able to produce damage intracellularly. Acetaldehyde, or the aldehyde form, after oxidation of alcohol, is responsible for the acute effects and the development of oral cancer. So the toxicity of alcoholism is due to acetaldehyde. It is good to note that us Asians, one half of us, will have naturally low alcohol aldehyde dehydrogenase activity. So we are really poor metabolizers of alcohol, which will lead to more common experience of nausea, flushing or pamumula, tachycardia, a fast heart rate, and hyperventilation, rapid breathing. So let's take a closer look into the toxicology of alcohol. Remember in the previous slides when we discussed the metabolism of alcohol that alcohol is progressively converted into aldehyde and then acetate. And that conversion utilizes NAD, and um, in the process produces the reduced equivalent NADH. So if that process continues on and on, especially in a chronic alcoholic, this will lead to low levels of NAD and high levels of NADH, which we call a high NADH to NAD ratio. And this impedes fatty acid oxidation and conversion to lactate, leading to hepatic steatosis and lactic acidosis, respectively. Remember in our past lessons when we discussed lipoprotein metabolism, how um, fat cells communicate with the liver through lipoproteins. These are substances that carry the fat so that it is soluble in the blood. So just try to recall that lesson and remember that the liver is a central regulator of the levels of fat in the blood. And how does it regulate that one? By altering the levels of lipoproteins and by metabolizing some of the fat that enters the liver. One of that metabolic pathway is the catabolism or the degradation of fatty acids. So, in your biochemistry, remember that um, this process is um, called fatty acid oxidation, and there are many ways of fatty acid oxidation. There can be beta and alpha, and in a minority of tissues, omega oxidation. So, here in the image in the right, you will see how a fatty acid is progressively oxidized through beta oxidation to liberate acetyl coenzyme A. Now, at the top of the image, you have the fatty acid that enters the pathway, and at the bottom of the image, you have released the acetyl coenzyme A after fatty acid oxidation. And this process in general leads to lower levels of fat in the liver cell because that fat is continuously degraded into acetyl CoA. So this process decreases hepatic steatosis or the accumulation of fat in the liver. Now, if you take in a lot of alcohol, remember that the effect is a decrease in the available levels of NAD and an increase in the available levels of NADH. So take a look at the image in the right and in the bottom, you will see that NAD is utilized by the fatty acid oxidation pathway so that it can liberate acetyl coenzyme A. If you have low levels of NAD, then you will be slowing down beta oxidation. And this will lead to an accumulation of fat in the liver. Furthermore, CYP-mediated oxidation leads to reactive oxygen species production, as what we have shown in the diagram prior to this slide. And the reactive oxygen species, if you will recall your organic chemistry lessons, will lead to a chain reaction, particularly involving the lipid membrane or the cell membrane. This leads to lipid peroxidation. Therefore, the integrity of the cell membrane of the liver cell goes down. And this poor integrity of the liver cell will lead to hepatic or liver cell injury. Alcohol causes intestinal microflora, which are the commensals, no? The bacteria that naturally lives, particularly in the large intestine. So when alcohol that you've taken into the mouth passes through the stomach, the small intestines, and finds its way into the large intestines, the bacteria in the large intestine, when it contacts alcohol, will release endotoxin. And endotoxin means these are bacterial products that are part of the structure of the bacterium, and they will elicit a strong inflammatory response. So these endotoxins will stimulate the Kupffer cells in the liver, which we have discussed as the special macrophage of the liver, to release pro-inflammatory cytokines. So what is illustrated in this image is how the venous outflow, remember that the circulation in the body will always have an artery, a capillary, and a vein. So um, the blood flow that goes into the large intestines will go into smaller arteries and capillaries and eventually into veins. And the veins, um, before they empty the blood that they carry into the systemic circulation will have to pass through the liver first, and this is the portal venous circulation. So the endotoxins that are released by the bacteria in the large intestine will first find its way into the liver. And here in the liver, it will encounter the yung endotoxins will encounter the Kupffer cells, which will release inflammatory cytokines. So those are the different toxicities caused by alcohol. You have impairment of fat metabolism, you have release of reactive oxygen species leading to liver cell injury through the cell membrane, and lastly, the bacteria that is in the large intestine will release a toxin which will stimulate the release of inflammatory cytokines by the macrophage of the liver cell. So let's now go into alcoholic liver disease. So whenever a person has acute or chronic alcoholism, the liver is affected. And remember the different toxicities that we discussed a while ago. All of those different mechanisms of injury to the liver will lead to alcoholic liver disease. No? And this causes 50% of deaths from cirrhosis. So what does this mean? Of 100 patients who have cirrhosis or very severe scarring of the liver, half of those patients, 50 of those patients with cirrhosis, have cirrhosis due to alcoholic liver disease because they took alcohol. There are three major lesions in alcoholic liver disease. And this is number one, fatty liver, which occurs in 90% of binge and regular drinkers. So that means the liver is filled with fat. Then alcoholic hepatitis, which means from those livers which have become laden with fat, there will be a small proportion which will have migration or infiltration with white blood cells. So let me emphasize that one. The first lesion is a fatty liver. You took in the alcohol and that impeded metabolism inside the liver cell and you accumulated fat. After that, a proportion of those who have fatty liver will then have inflammation of the liver, where the fatty liver will start to accumulate white blood cells. And that is already alcoholic hepatitis. And the inflammation that we have discussed a while ago will continue on and on. The liver being continuously injured and the Kupffer cells continuously being activated, releasing pro-inflammatory cytokines, which will continuously stimulate the hepatic stellate cells to release collagen, and that collagen continues to accumulate, and the number of liver cells continues to go down. That will eventually lead to cirrhosis. So remember this progression. First, you will have fat in the liver, and then next, those fat will have white blood cells, and then next, there will be increased deposition of collagen and decreased number of liver cells. Women are at higher risk of progressing in the alcoholic liver disease spectrum. So, what are the equivalents of 12 grams of alcohol? So, that is illustrated here in the image. No? 12 grams of alcohol means we take in one beer, that's equivalent to 12 grams, 4 ounces of wine, that's equivalent to 12 grams, and 1 ounce of a strong liquor or an 80% spirit, that's equivalent to 12 grams. So drinking that places one at risk means 7 drinks per week in women and 14 drinks per week in men. So if you go above 7 drinks per week, and if you are a woman, you are at increased risk of developing the more progressive form of alcoholic liver disease. And if you're a man, 14, so you have a higher tolerance. The lower tolerance in women is due to the effect of estrogen, body fat, and gastric metabolism. So take note that um, even if you do not exceed 14 drinks per week, if you are a man, those minimal intake of alcohol will still produce hepatic steatosis. So alcoholic liver disease carries a higher risk of cancer and progression if simultaneously infected with hepatitis C. So remember that hepatitis C is a virus which has tropism, or which has predilection to infect liver cells. So in patients um, who regularly take for social reasons or for um, physiologic and psychologic reasons alcohol, remember that most of them will also have risky behavior. For example, persons who party a lot, they will take in alcohol. Sometimes they will, no, not sometimes, but it is, you will find a higher chance that in them they will also have risky behavior of unprotected sex or IV drug use. So in those subset of patients and persons, if they have hepatitis C from unprotected sex or IV drug use, then that hepatitis C, together with the alcoholic liver disease process that we have discussed a while ago, will lead to quicker progression to liver cancer and cirrhosis. So here is an image that will summarize um, in general how the liver is damaged. No? So common causes of liver injury: hepatitis from viruses, you have alcoholic liver disease, and even if your liver just accumulates some of that fat, no, either because you have insulin resistance or you are obese, that leads to non-alcoholic fatty liver disease. So yung first three bullets in the left, those are the most common causes. But eventually those will lead to liver injury, and that is what we call chronic liver disease. So take a look at the middle where there are photos of the liver. First, there will be inflammation where white blood cells will enter the liver parenchyma. There will be fat accumulation or steatosis, and those will lead to cell death because the liver cell is injured. And the response to cell death would be to um, to undergo restitution or proliferation to replace those that have died. That will continue on and on as long as the insult is not removed. So that will lead to fibrosis. Next, the cirrhosis will occur. No? There will be continuous deposition of collagen and continuous dropout of liver cells. And if that occurs, the liver will contract upon itself, it will shrink, and it will become very rough and very hard. That is already a cirrhotic liver. And um, this cirrhosis, remember that not all of the liver will be affected at the same time. There will be portions that um, have still normal liver cells, and those regenerative nodules, we call them regenerative nodules. those that have not been affected by cirrhosis, that will try to compensate by regeneration. Those will be the seeds for cancer because they will have a high replication. Therefore, they will have a higher chance of developing malignancy that will lead to cancer. So, what is the point of this image? The point of this slide is cirrhosis can result from a lot of injuries, but cirrhosis can also lead to cancer. So, if you have cirrhosis, you can develop cancer. Okay, so um, eventually, because the liver becomes cirrhotic, there will be resistance to blood flow through the liver. Mahihirapan nang dumalo yung dugo through the liver because of those contractions from the fibrosis. And that will increase the resistance to blood flow through the liver, and that will lead to portal hypertension. So here are the clinical features of cirrhosis. Again, cirrhosis or chronic liver disease will present in a subtle way. What we see in these patients is unsuspected hepatomegaly. We don't really expect that their livers will be large, but when we examine the liver, it's large already. So that's unsuspected hepatomegaly. Right upper quadrant discomfort, which means in their abdomen, in the right upper quadrant, if we divide the abdomen into four, the upper portion on the right will be somewhat painful, or there will be a feeling of fullness. No? There will be nausea and vomiting. There will be fever, especially if there's hepatitis, spider nevi, jaundice, and portal hypertension. So right now, I want you to take a closer look at this person in the right. So remember that the liver is already cirrhotic and blood flow to the liver um, is already low because the resistance inside the liver is already high. So that blood flow to the liver will cause the blood to congest or to stay, to pull up in the organs that drain to the liver. So what are these organs? The gastrointestinal tract and the spleen. So dahil yung blood flow papunta sa liver from the stomach, from the small intestine, and from the large intestine is having a difficult time passing through the liver, then blood will dam up in these organs. So that is what you call portal hypertension. No? So what will be the effects of portal hypertension? So take a closer look at the right. That will lead to edema. Um, that will lead to esophageal varices, a large spleen, yung blue na parang bean shape dyan. That will lead to visible vessels in the abdomen, which is called caput medusa, and ascites, or fluid inside the abdomen. Remember that the liver does not admit blood, and the liver will continuously sweat. So, parang magpapawis yung atay, and that um, sweat from the liver, so yung pagpapawis ng atay, is actually edema fluid, and that accumulates in the abdomen. So what you will see in these patients will be a very big abdomen. And remember that in cirrhosis, the liver cell continuously goes down and the collagen deposition continuously goes up. Therefore, the number of liver cells will decrease. Therefore, the functions of the liver, which is to eliminate bilirubin, the one that colors our skin yellow, no? During jaundice, that level will increase. That will lead to jaundice, and you will see these patients being very yellow. So what is my point here? If you see a patient that is yellow, uh, think of the liver. And if you see in that same patient that the abdomen is very large, then think portal hypertension. If you think of portal hypertension, then imagine the liver being very shrunken, low number of liver cells, high amount of collagen. And so that is already end stage liver disease. Okay, so now let's go to the treatment of alcoholic liver disease. So let me emphasize this one. Complete alcohol abstinence is the cornerstone of treatment. This is associated with improved survival and even reversal of tissue injury. So remember that all those pathologic processes occur because there is alcohol that reaches the liver. And therefore, naturally, if we stop the insult, then we prevent further injury to the liver. Next, remember that there is a lot of inflammation occurring in the liver in response to alcohol. And therefore, another treatment option, especially in severe alcoholic liver disease, would be to impair the immune system. We are trying to suppress the damage that is brought about by the immune system against the liver. So through this, we use glucocorticoids, particularly prednisone. So the mechanism of action is it inhibits phospholipase A2, and you know this already, and this decreases the levels of arachidonic acid and therefore the levels of substances that are derived from arachidonic acid, such as prostaglandins. It inhibits humoral and cytotoxic immunity. So remember that glucocorticoids will prevent the transcription of genes that are involved in the development of plasma cells and cytotoxic T lymphocytes. So that means those cells will not be able to produce antibodies that will injure the liver, and those cells will not produce lymphocytes that will directly kill the liver. These are given to patients with severe ALD, and the contraindications are active bleeding. Why? Because when you give glucocorticoids, you will be preventing the formation of thromboxane, which is needed to stop acute bleeding. And at the same time, you will be preventing the formation of prostaglandin, which um, provides cytoprotective activity on the gastric mucosa. So if you don't have prostaglandin, then the gastric mucosa will continuously ulcerate. Okay, so that is why active gastrointestinal bleeding is a contraindication. Renal failure is also a contraindication because, again, you need prostaglandin for blood to reach the glomerulus, particularly in the afferent arteriole and pancreatitis. So here illustrated in the image in the right is how your glucocorticoid will produce its effect. It will bind to GR, the glucocorticoid receptor, and that will lead to glucocorticoid response elements, GRE activation, and that will eventually lead to anti-inflammatory effects. Um, Concurrent to that will be a decrease in the levels of cytokines, chemokines, inflammatory proteins, receptors, enzymes, and adhesion molecules. So it will create an anti-inflammatory effect and it will subside the pro-inflammatory effect. And lastly, another treatment for alcoholic liver disease is pentoxifylline. Pentoxifylline, if you remember, is a derivative of the xanthines. Okay, so This is a non-specific inhibitor of tumor necrosis factor alpha. TNF is a pro-inflammatory cytokine. So when we give pentoxifylline to patients with severe alcoholic liver disease manifesting the hepatorenal syndrome. So this is nice to know already. Hepatorenal syndrome means because of the liver disease, the kidneys can't receive enough blood flow. So in those patients and in patients with really severe alcoholic liver disease, by giving them pentoxifylline, you improve their survival. More of them will live after being given pentoxifylline. So remember that as you take a closer look at this image, liver injury will stimulate the Kupffer cells to release tumor necrosis factor, and that TNF will lead to the death of liver cells, and at the same time, um, the activation of hepatic stellate cells, which will lead to deposition of collagen. So that TNF kills, so that substance, TNF, will kill the hepatocyte and at the same time increase the deposition of collagen. So if we block TNF by giving pentoxifylline, then we can slow down the pathogenesis of cirrhosis. So that's it for our last slide. Remember, alcohol destroys the liver, and that effect of alcohol is due to acetaldehyde. It's due to impairment in fat metabolism in the liver. It's due to um, damage to the cell membrane of the liver cell and due to the release of microbial byproducts from the intestines, which will continuously activate the Kupffer cell in the liver, leading to death of liver cells and an increase in fibroblasts or collagen being deposited in the liver that will lead to cirrhosis, low number of hepatocytes, high amount of collagen, which will then prevent blood flow from the gastrointestinal tract to exit into the systemic circulation, and that will lead to portal hypertension. So that portal hypertension will be the ones that cause majority of the morbidity from chronic liver disease. So how do we treat alcoholic liver disease? The cornerstone is to stop intake of alcohol. You block inflammation um, non-selectively through glucocorticoids or selectively through pentoxifylline, which will inhibit tumor necrosis factor. So with that, I hope you learned a lot with this lesson. Thank you.